Welcome to this explainer on general history taking. Whether you're just stepping onto the wards for the absolute first time or you're already deep into your NEET PG preparation, you really need a high-yield, academically rigorous framework for mastering clinical examinations. I am super excited to guide you through this today because honestly, this is the absolute bedrock of diagnosis. We're not just learning how to talk to patients here, we're learning pure clinical detective work. Okay, so here's our roadmap for this 5-part clinical framework. We'll be hitting the foundation, unpacking the present illness, documenting the past, personal and family context, and then wrapping it all up with a real clinical Proforma in practice. Let's get right into it. Section 1, the foundation, objectives and demographics. This is all about establishing exactly who the patient is and why we're gathering this data in the first place. So the absolutely crucial thing to remember is that our ultimate goal here isn't just having a polite chat. The primary objective of taking a history is the highly targeted extraction of information about the patient's present illness, their personal habits, and their family history. And why do we do this? Specifically to formulate a provisional differential diagnosis. Every single question you ask should be deliberately driving you toward that specific diagnostic endgame. Now, before you even think about touching on pathology or symptoms, you've got to systematically record these 7 essential particulars of personal data. We're talking name, age, sex, race, occupation, marital status with children of any, and their residential address. This data firmly grounds the patient's identity. And hey, for your exams, keep in mind that critical epidemiological clues often hide right here in the patient's address or their occupation. It's high-yield stuff. But look at how standard patients compare to critical exceptions. This brilliantly illustrates a classic exam scenario that's really going to test your clinical judgment. While standard, stable patients will sit there and give you a full chronological history first, you absolutely cannot rigidly apply this rule everywhere. If a patient is unconscious, well, you might not get a history at all. In critically ill or medical emergency scenarios, that history has to be kept incredibly short, and treatment literally must begin even before the history is completed. Never, ever delay a life-saving intervention for paperwork. Moving on to Section 2, unpacking the present illness, the core complaint. Let's dive into the very heart of the diagnostic puzzle. The history of present illness is where your clinical acumen truly shines, and you have to structure it precisely using these 4 steps. Step 1, record the chief complaints chronologically. And this is key, always, as far as possible, use the patient's own words. If they say they have a belly ache, write down belly ache. Don't translate it into abdominal colic right off the bat. Step 2, determine the onset. Did this happen rapidly or was it gradual? Step 3, establish the duration. Has it been short or prolonged? And finally, step 4, evaluate the progress. Is their condition progressing? Is it stationary or is it regressing? You know, the technique here is honestly a delicate art form. You want to allow for spontaneous narration. The account should just flow freely from the patient, while you, as the physician, merely guide the narrative where necessary. You have to be incredibly careful to avoid any leading questions that might put words in their mouth. And once they've outlined the disease, you always need to ask about those diagnostically important symptoms they might have forgotten. Make sure to nail down aggravating factors, relieving factors, and absolutely any past treatments they've already tried. All right, Section 3, documenting the past, hidden clues. What's really fascinating here is how seemingly remote historical details can directly dictate your present clinical picture. Taking a complete past history mandates cycling through these specific headings. You're basically hunting for clues. Check for similar illnesses first, then scan for major chronic conditions. Think diabetes mellitus, hypertension, thyroid issues, or asthma. Definitely note any past operations. You also must ask about venereal diseases or STDs when it's relevant, and meticulously document all allergic reactions. Finally, especially if you're dealing with pediatric cases, make sure you cover infectious diseases, vaccinations with their last booster doses, and the mode of delivery. Section 4, personal and family context, connecting the dots. Let's expand our view a bit and examine the background factors that are so frequently tested as diagnostic pointers in your academic assessments. To really gather a comprehensive personal history, you need to rigorously investigate these 9 areas. First, we look at their daily baseline, so that's appetite, diet, sleep, and bowel habits, along with micturition history and, for women, their menstrual history. Then we document habits that include smoking, alcohol, or even if they're drinking excessive amounts of tea or coffee. Finally, we assess occupation and socioeconomic status. These frequently act as direct pointers to very specific pathologies. Okay, pay really close attention here because these associations are absolute gold for your NEAT PG prep. This directly links historical elements from our source texts to their classic diagnostic endpoints. A history of rheumatic fever in childhood, that points straight to valvular heart disease. A recent loss of appetite in an elderly patient could very well point to stomach cancer. A smoking habit strongly predisposes a patient to lung cancer or ischemic heart diseases. Now, interestingly, based strictly on our clinical source texts, occupation in the asbestos industry is noted as predisposing to tuberculosis of the lung, so keep that textbook quirk in mind. And finally, a neighborhood measles outbreak points toward an exanthematous fever diagnosis. Definitely keep these classic textbook associations locked in for your multiple choice questions. Moving over to the family history, we have to investigate a pretty wide range of factors. Yes, of course, we look for similar illnesses and hereditary disorders like diabetes, hemophilia, or hypertension. We're also checking for a family history of sudden death or allergic disorders like asthma and eczema. But we also need to evaluate the environmental factors. Getting information about socioeconomic status, overcrowding, and malnutrition in the family is absolutely essential. It's not just for diagnosing infectious diseases, it's vital for planning effective, realistic treatment for your patient. Finally, Section 5, Clinical Proforma in Practice, a real example. Let's ground all this academic theory by taking a look at how it actually looks on a physical document. Looking at these handwritten records, we see a standard baseline for an 18-year-old female medical student. What I want you to notice is how the negative histories are properly and clearly recorded. Under history of present illness, treatment history, and history of past illness, it simply states none. Under personal history, we see normal appetite and regular menstrual history. It's a perfect example of how an unremarkable, healthy baseline is efficiently documented in a fast-paced, real-world setting. So, to conclude this explainer, I really want you to consider this. With this rigid, systematic academic framework now firmly locked in your mind for your exams and your word rounds, how are you going to successfully pivot and adjust your strategy the very next time you face a critical emergency where treatment simply cannot wait? Reflect on that delicate balance between thorough data gathering and rapid clinical intervention. Keep studying hard, and I will see you in the next explainer.